Okay, so I'm going to talk about a piece of work that we've been doing with Liz Ashall-Payne and from the North West Coast AHSN and Clive Flashman from CSC, our industry partner, and my other colleague is Tilly Reid, who's also at the University of Cumbria. And it's to look at organisational readiness for telehealth adoption and why we're not able to sort of implement what is obviously, I say it's obviously, I think it's something that as patients we think is obvious, that we ought to be able to implement digital technologies to improve our health outcomes, but there are significant barriers to the health service being able to move forward with it. Yeah. So the opportunity in a nutshell is, why can't we get our healthcare in the same way that we get our banking, shopping, socialising, all those things that we're starting to take for granted. So we could live in a world where it's just, booking appointments, going to hospitals is just like booking a hotel room. All your records are there when you get there. You can communicate with your doctor by whatever means is convenient for you, email, Skype, FaceTime, whatever, video links. And everyone will be able to see the same information. Okay, so that's the opportunity. Yep. But for some reason, there are a number of challenges. So there's all sorts of reasons, and these are really valid reasons from the various stakeholders, from the staff, from the patients, and from the managers. So a whole range of questions. I won't read them out. You can read them, but many of them are valid. Many of them can be overcome, but they need working through. And the message is really that digital health is a disruptive technology. It's disrupted the landscape in other industries. So, we're seeing significant change in the retail industry. It's obviously going to disrupt the health sector as well. It has potential to radically alter how we deliver healthcare, but it's a complete change to the systems, and that's why it's not a sort of off-the-shelf thing that we can just plug in and use. So just I don't know how legible that is. Is that just a quick break to do some definitions? Most of what I'm talking about is digital health, which applies to the whole range of areas, so including telehealth, where patients collect data either through sensors or through data entry, and they record the data and share it with their clinicians remotely. Telemedicine, which is about remote consultations, video links, and sharing of images and real-time video and sound. E-health is about systems, underpinning systems, patient records, electronic health records, and assistive technologies and telecare, which is more in the social care sector. So primarily what we're focusing on in this project is telehealth, but I think a lot of the comments are relevant to all of those. So at Cumbria, we've developed the stakeholder-empowered adoption model, where we look at the barriers to adoption and the benefits of the technology to all the different stakeholders, and that's the professional users, the staff, and the patients, but it's also the managers and the commissioners and the suppliers. And those can often conflict, and because they have different values, different goals, they can sometimes conflict, and that's the cause of the problem of telehealth not becoming adopted. So we've developed a framework, and we're doing a number of case studies at the moment, looking with NHS trusts and with companies to improve the adoption process. And we've actually got standouts out one of those rooms out there that all look the same, and you can come and find out a bit more about it there. So I guess it was 9 or 10 months ago, we embarked on a piece of work with CSC, and we were going to apply our telehealth adoption process to a trust in the North West Coast region, and use that also with the a process that CSC do, which is their business case, outline business case development process. Two fitted quite well together. So we went into this trust, and their motivation was they were interested in adopting telehealth. They were interested in it primarily because they knew they had a problem with supporting patients with long-term conditions, and particularly COPD. That was the focus they chose, but also specifically to address hospital admissions and readmissions, unplanned readmissions. So that's actually fairly typical to have those reasons to look at telehealth. So it seemed like a good project. And we started off by having conversations with a range of stakeholders. So that included the trust directors and managers and the staff who were who would be likely to be involved. And we also talked to a patient group. And we looked at data as well, and so we did quite a look at the landscape. What happened was, we decided after quite a detailed piece of work that we couldn't recommend that they implement telehealth because of a range of problems with the trust itself and with that health and social care economy. They didn't have appropriate intermediate care structures to operate without telehealth, so bringing it in wouldn't really change that, it wouldn't solve the problem. There were actually other services in place by other organisations with the other providers, which was confusing to the GPs and to the patients. There was the health and care economy was not really well integrated. They weren't really talking to each other. They certainly didn't share objectives and goals as they do in some other areas. In that particular area, it wasn't working well. And we thought actually they hadn't really defined the problem they were trying to solve and the benefits that were likely to be to patients. They hadn't really thought that through. So the conclusion was that the organisation was not telehealth ready. And this isn't that unusual, I think. There's a perception quite often that we have a problem, let's try telehealth, or let's try something else, another technology, and without having all the underpinning elements in place. So that's quite common. The other thing that's quite common is also that I think the staff feel threatened because it's brought in as a cost-cutting, or it's perceived to be brought in as a cost-cutting measure. So that didn't help either. And whether it's true or not, I mean, we didn't actually sort of know that at the time, but it's a perception, and it's obviously a perfectly valid and real concern. So we went back to the AHSN and said, we can't really do what we thought we were going to do. It's not going to work. What should we do? So we came up with the idea of developing a telehealth readiness tool, which will enable organisations to self-score against a number of criteria and questions and do a little assessment. And then they will have resources to improve in the particular areas. And we've from our experience with that trust and with other work we were doing, we could identify what some of those elements were, and we've done a piece of work working through as a team to look at all those, what's been written in those areas and what we've found from our experience, and we've come up with a list of areas which I'll talk you through in a minute. And and it's very much drawn from the needs and understanding of North West Coast organisations. So this is the tool we're planning, by the way, Liz is pushing us to launch it on the 20th of January at I think it's the Connected Health Day, is that what it's, got that right? So we'll be a little bit further on with it then if you're at that event. But at the moment, these are the 4 domains. So these encompass a number of areas, overlap slightly, but we've split them into domains, and then underpinning that, there's something about technology and infrastructure, which is not really it's more a sort of things you need to think about. It's more a checklist. It's not a sort of scoring matrix in the same way. And it'll look a bit like this. So you work through a series of questions and score yourself and get a little spider diagram, and then you can see the areas you're weak in and work through the resources and go back and try again. So just going into some of the detail, the partnership working is obviously actually critically important, as we discovered in the study we did and from experience elsewhere. It's very important to think about partnerships with other organisations who are going to deliver part of the service, because very often digital services involve emergency services, they might involve social care in some peripheral way, and if those aren't thought through, then it won't work. So there's an important aspect about that, sharing of goals. I think the question of who should lead it is also important, because some of the problems we had with the project I've alluded to was that there were different providers, a community trust and an acute trust doing different elements, and things are done very differently in different areas, and that needs to be worked through. How should it be led? Who should be the lead partner? And there are many opportunities that are overlooked, I think, for involving voluntary and third sector partners, so we thought we'd give a bit of guidance on that as well. Patients and public are absolutely critical, obviously. In my experience, actually, the patients will embrace a disruptive technology if they can see the benefits far more readily than professional staff will. And I think the difficulty is showing the benefits to the professional staff. But nevertheless, the patients need to be thought about very carefully. And I think one important thing is understanding which of the patients that can benefit. There's a sort of, there can often be an assumption that we'll just give this to everyone, and it's not always appropriate. So that needs to be carefully thought through, and understanding what the scale of that is and what the numbers are. The whole ethos is to enable patients to be self-manage, which changes very much the way clinicians work with patients, so that empowerment of patients involves a different professional relationship, which is not always well understood. And then the patients themselves need resources, they need communications, they need materials and signposting perhaps to other information sources. So the organisation is, I think, actually, in my opinion, is the major area for to work. Well, that and partnership working, I think the organisation is often where the most barriers occur. And it's very often because, very simply, people's jobs are going to be changed, and they may feel threatened by that, but they may also not feel they have the skills, and that's often overlooked. So one of the things that we're also working on is telehealth training, and looking at training for nursing staff and allied health professionals and other medical professionals. So, yeah, and then I think there's the financial model is the other aspect, which is a lot of pilots are done in a sort of little silo. Somebody has a bright idea, they get a bit of funding, and they do a very simple cost analysis, and they often overlook the impact on other areas. So I'll skip that one because my time is up apparently. But the next steps are that we're aiming to complete the tool in early 2015, in January. And we're then looking for partners to pilot it with in the North West Coast region. And we're also already talking to NHS England about a national rollout and where it can go to next. Okay. Finally, the contact details. Thank you.